Hello, everybody. Let's go ahead and get started here. First of all, I want to welcome you all for our annual Greg White Levitt Lecture. I'm Myra Muramoto. I'm the Department Chair for Family and Community Medicine that hosts this lecture series. I want to give a shout out to really everybody's chosen to participate. I think we're going to have close to 100 people here in the room and another 200 online. So I welcome everybody that is joining us remotely. I think this is maybe one of the biggest audiences we've ever had. And I really am proud of us in terms of being able to expose people beyond the Anschutz campus to the good work that's being done here by CSTAHR. So the Levitt Lecture, just to tell you a little bit about it, it's the Levitt Distinguished Speaker Series. And this particular lecture, which is one a year, we dedicate to the memory and honor of Greg White, who together with the students founded CSTAHR, and India Bond is going to tell you more about that. But that's a community and students together against healthcare racism. So the history of this particular Levitt series, Dr. Louis P. Levitt was born in Denver in 1896 and graduated from CU School of Medicine in 1927. So this goes way back. He practiced medicine in Denver until 1967. And in 1978, he bequeathed $75,000 to the department to endow a lectureship series, which is what sponsors our ability to bring in speakers from around the country. And that basis of philanthropy is really spreading the work we're doing, bringing more thought leaders in the field to talk about topics that are really relevant to primary care. And also to help primary care is continually evolving and to bring up to date and current information and about what's going to be happening in the field. And today's particular topic around data is particularly important as you know, there's lots of talk around AI and data and the power of data to transform healthcare in ways that are good and maybe not so good. And there's excitement and anxiety about it. And today I think you'll get a sense of why that's the case. Am I getting that? Can you guys hear that? All right, we're okay. So just to let you know, because of the student schedule, some people may need to leave at 1 o'clock, just to let you know. And so they apologize in advance for that. And in case you missed something, the event is being recorded and it will be able to be accessed on our department website. So I want to welcome India Bonner to introduce CSTAHR and our speaker.
Hi, everyone. Thank you so much for coming today. My name is India Bonner. I'm a third-year medical student. Sorry. And I am one of the student leaders for CSTAHR. So CSTAHR is a student-led organization, community and students against healthcare racism. And we work a lot with the community to learn about how bias and racism shows up in healthcare and how us as future healthcare providers can be advocates to address racism in medicine. So some of you might be wondering why the name Greg White came about. And instead of me standing up here and talking about his legacy for you, we actually have a really excellent video that has comments from different community members, different resident physicians and students about Greg White's impact on them and why this series is named after him. So I'm going to play that video.
Greg White. He was a complex person with lots of layers.
So I think I would describe Greg as someone who was just incredibly committed, really dedicated to working towards health equity and using his own experiences to help inform how we can create a more just healthcare system.
Greg was a very unique kind of guy to me.
Some of the adjectives that I would use to describe him: passionate, unapologetic. He was just overall just this wonderful, genuine human being that I think had a really difficult life, and in my mind found a way to heal through CSTAHR. Hi, I'm Erica Martinez. I am currently a third-year resident at Stanford University.
Hi, I am Bella Mohapatra. I'm a family physician that works at Clinica Family Health.
Hi, my name is Mackenzie Garcia. I'm a fourth-year medical student in the MD and PH program at CU.
Hello, my name's Michelle Wheeler, and I'm a founding member of CSTAHR.
I think that CSTAHR really meant a lot to him because it was one of his ways of using all of his experiences with racism and the trauma associated with that to make our community better.
He helped create CSTAHR. He chose to invest in us and chose to teach us because he wanted to make healthcare better for people.
I think he valued most the relationships that he had with the students. He really thought that they were going to change the world in terms of, getting rid of racism in healthcare. He always kept us on track. He would always steer the conversation back to, so what are you going to do? And not just the individual. What are you going to do as a group? What is CSTAHR going to do as a group to end, racism in healthcare?
So this is a letter that I wrote to Greg. It was really just more of a personal reflection for me. I wrote it the night that he died. Dear Greg, I should have written this when I could have read it to you in person, but I missed that chance. So this is the best I can do. Actually, the best I can do is work throughout my life, like you did, to make the world a better place. I promise to listen to my patients with my whole heart, to consciously evaluate my own biases and the impact that my perceptions have on other people, and to work with others to create the world that you envisioned.
I know I'm going to be a better physician and a better surgeon for my patients because I met Greg. I think that his legacy was that each of us are going to carry a little bit of him to all of our patient encounters, to all of the projects that we're a part of. Speaking on behalf of all students and all current physicians, residents, everyone who has interacted with the CSTAHR community, I feel very confident in anyone who has known him that they are going to continue to work to fight against racism and discrimination in every way, shape, or form.
Greg White has inspired and continues to inspire us all to work towards making our healthcare system more just for all of our patients. We're so thankful to be here today to continue to honor his legacy. So our keynote speaker today this year is Dr. Elaine Nsoesie. So she is an associate professor of global health at Boston University School of Public Health. And her research is currently focused on the use of data science methods to study the impact of policy on racial health inequities. She served as the faculty lead for the Racial Data Tracker Project at Boston University Center for Anti-Racist Research. She's passionate about increasing the representation of underrepresented communities in data science. She's on the advisory boards of the Data Science Africa and Data Sciences Network, and she's also a data science faculty fellow and was a founding faculty of the Boston University Faculty of Computing and Data Sciences. She holds a PhD in computational epidemiology and a master's degree in statistics from Virginia Tech. She is incredibly accomplished and she has done so much work in this area. So before I bring her on the stage today, I just wanted to remind you all that after her talk, we will have a small Q&A session so that we can ask more questions to her and further discussion. That's going to be at 2 p.m. in the academic offices building on the 3rd floor in room 3101. So if you have the ability to stay and talk to her more, that would be amazing. All right, and please welcome me. Please help me in welcoming her to the stage.
Hi, everyone, and thank you so much for being here. I hope you can hear me in the back. All right, great. So today I'm going to talk to you about data algorithms and racial health equity. And I'm going to start with a story. A couple of years ago, the School of Public Health at Boston University organized a symposium on anti-racism as public health policy. We had a range of speakers, very different backgrounds. So one of our speakers was Professor Patricia Williams, and she talked about an experience that she had while visiting her doctor. So she'd gone in for a regular checkup for osteoporosis and osteopenia. And she was talking to the doctor, and the doctor was using an algorithm to generate questions that he was then asking her. And at some point, the doctor stopped asking questions. And she knew the doctor was using an algorithm. So she said, do you have a race? Do you have within the algorithm, is there a point where you have to specify my race? And the doctor says yes. And she says, can you change it from black to white? And the doctor did exactly that. And suddenly the algorithm had more questions. And it began asking her about her family history with osteoporosis, asked whether she'd had falls in the past. And this was a very good example of how algorithms that are used to automate decisions can have significant impact on health care. So by just changing her race from black to white, she got much better care with just one single change. But you have to know that. So if someone goes to see a doctor and they don't know the doctor's using an algorithm, they can't actually tell them to change that variable in an algorithm and then change the way they receive care. So this is what drives most of the work I do. I think about health equity and how we can use data and algorithms to advance health equity. And I always like to start with the definitions just to make sure we're all on the same page. So I define health equity as the assurance of the conditions for optimal health for all people. Achieving health equity requires valuing all individuals and populations equally, recognizing and rectifying historical injustices, providing resources according to need. Health disparities will be eliminated when health equity is achieved. Racial health equity is health equity. I don't think I need to say that to this room, but I just wanted to say that. And we can't achieve health equity without achieving racial health equity. I also like to show this visually because sometimes when I talk about equity, people think about equality, but they're not the same things. Equality means that we all get the same thing, regardless if it's needed or right for us. Is that better now? While equity, on the other hand, means that everyone gets what they need. And we have to take into account the conditions and the circumstances and the factors that prevent people from achieving optimal care. Equity sometimes also means that some people get more than other people. And that's something that we're not always comfortable with because we don't always think about equity in that way. But if someone else needs a lot more to achieve optimal health than I do, then they should be getting more of whatever that resource is. So as I mentioned, a lot of my work is around data. I think a lot about data and about algorithms. And every day we're constantly producing data. And this is the kind of data that I tend to look at. So the data we produce on our mobile phones, the data we produce when we go on the internet, the data we produce when we check emails. This data tells a lot about us. So in this visual, for example, if you're on social media, your friendship network can reveal information about your race. Your photos can tell a lot about your age, your search history. So if you're using Google for searches, it can talk about your occupation, but it can also tell about your medical conditions or other things that you're seeking help for. When you share your location, when you use your mobile phone, that can tell a lot about where you live. So as we use mobile devices or digital technology, we're constantly producing data. And a lot of the work I've been doing has been around answering this question of how can we use this data for good? Because someone is using this data, someone is collecting this data, and most of the time the data is being used to make money or to influence us so we can buy more products, we can spend more time on social media. And I'm trying to think about ways in which we can repurpose this data and use it for public health good. So I've worked with data from several different sources. Crowdsourcing is basically when you opt in to share information about yourself. So the flu near your app was an app where you can sign up, and every week you will get a reminder. You can fill out a survey to talk about your symptoms if you have any flu-like symptoms, or if someone in your household has flu-like symptoms. I Was Poisoned was a foodborne illness surveillance website where people go and talk about foodborne illnesses. So if someone ate at a restaurant and they feel like the restaurant is to blame if they got sick, they would go to I was poisoned and share that information. And the way we use this data was trying to look at whether groups of people were reporting at the same time. So one person can have an experience, have an incubation period before seeing symptoms, and it might not be because they ate at a particular restaurant, but you have a group of people who go out to a restaurant and eat, and suddenly they're all sick. That's a very strong indication that it's because of the restaurant. We've done a lot of work around search data. So using data from Google, when people go to Google and search for things, looking around things like how people search for influenza-like illnesses or influenza symptoms, and how that can inform us about influenza prevalence in different communities, not just in the US, but also in Africa. UpToDate is a clinician support website. We've also looked at that for influenza surveillance specifically. Social media data, millions and millions of data that people are producing every day. We've looked at that data for a range of different issues and conditions. Consumer reviews data is one that has been very interesting, and that one has really focused around food safety. So when people go out to restaurants, they eat, they would go to a website like Yelp and write a review about that restaurant. And sometimes they will complain about foodborne illness. And that data can be really used for departments of health. So New York City Department of Health, for example, was able to find a lot of outbreaks that were happening in their communities by looking at what people were posting on Yelp. We also looked at Amazon data specifically to create a food safety surveillance tool using AI, where we wanted to be able to inform the FDA quicker about food safety rather than waiting for weeks after lots of people have been sick before they get that information and start investigating. I'm going to give specific example of our remote sensing news data. We've used that mostly for outbreak surveillance, and the mobile phone data has a lot of different uses. And I'm going to talk about a specific example from COVID. So even though there is so much data, and a lot of the time when I'm doing analysis, I'm looking at millions of data points, it doesn't mean that everyone is represented in this data, and it doesn't mean that everyone is represented in this data in the same way. And that's what we were starting to find several years ago. So when we looked at the tools that we were building for foodborne illness surveillance, what we realized is that we were really serving mostly higher income neighborhoods, and lower income neighborhoods were not being represented in this data. So I began to ask the question about representation. So who's actually in the data sets that I'm working with, and how are the tools that I'm developing impacting different communities in the US? A second question that came up was, how are different groups represented in this data? So it's one thing not to be represented, it's another thing to be represented, but represented in a way that is biased or in a way that's very stereotypical. And this is just an example from a recent publication in NPR that showed, so a group of scientists were trying to use an AI to create a photograph of a Black African doctor taking care of a white child. And the AI just could not imagine that. And when it got close, it looked something like this. So just imagine working with all those beads on your hands and everything else, but it just couldn't imagine creating a photo of a Black doctor, Black African doctor to be specific. And the reason for that is when you look at global health data, most of the time, the photographs of white doctors taking care of brown and Black kids. You don't really have photographs of Black doctors taking care of white kids. And so that's what AI has been fed. That's what it's been trained with. So when you go and ask it for information, it gives you back what it knows. And when you force it and say, I want you to create what I want, it ends up creating photographs like this. And in some cases, you actually had elephants standing next to the doctors because they're from Africa. So anyway, so the point here is there's a lot of bias that can be represented in data, especially data that has a lot of historical policies that have either been racist or sexist. But when that data gets fed into an AI algorithm, it just reproduces exactly what has been fed. And there was this beautiful paper that I was reading a few years ago talking about how we classify countries and people and why it matters. And the argument it was making was that the practice and vocabulary of global health and global development today have their origins in racism and colonialism, which has created a false hierarchy among nations, ascribe a higher value to some lives, and allowed some groups to extract, exploit, and subjugate others. And when you look at a lot of that data, historical data, that we are using today, whether we're scribbling from the internet or other sources, it just carries a lot of racism and a lot of colonialism. I know I've said a lot of things that are troubling, but despite that, data can also be useful in showing us where racial disparities and inequities exist. And I'm going to give you one example from the COVID pandemic that I really love, which is the COVID racial data tracker. So during the COVID pandemic, we knew that a lot of people were being impacted, but we didn't really have information how different racial and ethnic groups were being impacted. That data was not publicly available from the CDC. So people like Ibram Kendi began to ask the question of where is the data? How do we know what the disparities look like? And how can we identify the fact that different people are being impacted and create policies or interventions to change the course of the pandemic if we don't have this data? So in public health surveillance, timely data is extremely important because when you have timely data, you can implement interventions quicker and you can actually change how the burden of disease in different populations. If you don't have data and you don't have information about who's actually being impacted, then you can't create those interventions that can have significant impact. The data was not available from the CDC. Some states were reporting data, but the way that they were reporting data was, there were lots of differences. Different states were using different racial and ethnic categories. It wasn't consistent. The way it was being updated wasn't consistent. And it wasn't in one place where we could compare and say, this is how different people are being impacted in different states. So that led to the birth of the Racial Data Tracker, which was a collaboration between the COVID tracking project at the Atlantic at the Center for Anti-Racist Research. And the project ran for 1 year, included many volunteers, advocacy groups, people who were focused on data collections, the standardization and analysis. And the goal was to compile the most complete and up-to-date COVID racial data available from state-level public health reporting. And this is what the data showed at the end of the project. It showed that in terms of deaths, African Americans had the highest death rates. In terms of cases, Native Hawaiians and Pacific Islanders had the highest cases. And this was extremely important to see because it wasn't coming from any other place. And so data can have a lot of power depending on how it's collected and the purposes for which it's collected for. Some of the major findings from this project was that a lot of racial and ethnic data is incomplete. The data that was coming from the states was incomplete a lot of times. So you will have data being reported for some groups on some weeks, but not reported in other weeks. Or you will have data on hospitalizations, but not have it completely presented. So about 50% of the data might be presented. States also had very different reporting methods, and they did not always adequately account for ways in which race and ethnicity intersect. So you might have data reported for Latinos, but you would have data reported for Black Latinos, for example. States also use very non-standard race and ethnic categories, so it was very difficult to compare across different states to see whether they were actually seeing the same things. And some states reported the bare minimum or nothing at all. And states very infrequently updated the data. So that made it really hard. So the findings from this project led to a project that I led called the Racial Data Tracker. And the Racial Data Tracker was building on the COVID Racial Data Tracker project. The objective was to collect, analyze, and disseminate publicly available racial data that points to the structural nature of racism. And we wanted to make data easily accessible. We wanted to make data easy for anyone to understand. And we were using visualizations. We were creating data tables. We're creating narratives that anyone could access and use. This is what the website looks like. If you scan the QR code, it'll actually take you to the website and you can interact with it and see if it's useful for you. We focus on two specific topics, the racial wealth gap and health and social safety net. And for this topic, we have a range of visualizations on different variables showing disparities. And then we also have narrative around that topic. And then we have data that you can download and work with if you're interested. We also wrote a policy report making recommendations around how we can improve racial data reporting in the US so that it has more usefulness, not just for studying disparities, but also thinking about policies and policy correctives. So the next point that I want to make is that bias data used to train algorithms can worsen racial health inequities. I think I've talked a little bit about this already. And I think there's a lot that we can all do because we're all being impacted by algorithms in one way or another. And there are some questions that we should all be asking. Questions like, how do we want AI to be developed and deployed? Right now, there are certain people that have more power over this, especially talking about AI that has a lot of large-scale impact. So should those people be the only ones developing and deploying AI? And this is one of the things that in my head, the project that I led at National Institute of Health was trying to get at, trying to train communities that are underrepresented in the AI space and provide the infrastructure, the research tools that they need to be able to create AI algorithms to address problems that impact them. Yeah. Other questions that we should be asking around how AI tools are impacting us, I think it's important for us to know so that we can actually do something about it. And how can we develop AI tools that benefit historically marginalized populations? This is one that I think about a lot and one that I'm trying to work on. A report from Stanford University stated that the number of incidents concerning the misuse of AI is rapidly rising. According to the database, the AIAAIC database, which tracks incidents related to the ethical misuse of AI, the number of AI incidents and controversies have increased 26 times since 2012. And these are issues related to the use of AI, not just the use of biased data to train AI algorithms. And so I think that's something that's important for us to think about. And we had the question of, if the data that is being used to create these algorithms is already so biased, can we even create AI that is useful for anyone? And so what we were asking for this particular paper is, there are already so many structural issues, structural racism in the systems that produce this data. And if that data then is being used, which it is being used, to then create these algorithms, how do we even go about creating algorithms that benefit us? I don't know how many people know about race-corrected algorithms. So this is something that was in the news a lot in the last few years. And there are algorithms that are being used, for example, to calculate your risk of death. So you go to the hospital, you get tested for a particular condition, and there's an algorithm that will calculate your risk of death. But some of those algorithms, if you're Black, your risk gets reduced, and there's not always an explanation. So you get either added a number of points or subtracted a number of points. And that can be really significant for people's health. I had a colleague who had kidney disease, and he went from not being considered severe to suddenly being considered severe just because someone changed a number in the computer. So these are all things that are impacting health in different ways. And for some of these decisions, there isn't actually a good explanation of why those decisions are being taken. Some of them are rooted in racist assumptions and how Black people operate biologically. And then for others, they're just there. No one really knows how they came to be. But there are still some people who argue for keeping them. And there's a lot of discussion around whether they all should be changed or which ones need to be changed. So historical policies, whether the ones that are being used to correct algorithms or the ones that have been implemented in communities, continue to shape health. There's a lot of studies around how policies like redlining are impacting health, and these policies impact how data is collected, what data is collected, and how the data is used. This is a good example. Facial recognition is one that has been talked about a lot. So when you go to an airport and someone wants to use a facial recognition software on you, you're supposed to be told that you can opt out of it. But how many times, if you've ever been at the airport, have you been told that you can actually opt out of it? Usually you're not. Never. But that's policy. That's what the policy is supposed to be, because facial recognition software does not work for everyone. And in cases where it fails, it can have very significant impact on people's lives. The bias algorithm can limit access to care. There's so many more examples. This is another example that came out during the pandemic. It was already being talked about, but there were specific examples that were given during the pandemic around measuring oxygen saturation and how it doesn't work for darker skinned people. This other study was published in 2019, and it was looking at data for an algorithm that was being used at a hospital. So the algorithm was trained based on healthcare expense. And what it was doing, it was supposed to assign resources, so decide what patients should get additional resources. And when you look at Black and white patients, for Black patients, they had to be a lot sicker than white patients to get the same access to resources. And the reason why that was happening is because it was using data based on healthcare expenditure, where it was assuming that because the amount of money that was spent on Black people's health was a lot less, it meant that Black people were healthier. And so therefore they didn't need more resources. Algorithms can also be used to reduce racial inequities, but that requires an intentional effort. So there's a lot of conversations around AI and how AI is going to take over everything. But for AI to take over everything, we have to let AI take over everything. If we are intentional in actually creating policies and creating legislation that regulates how AI is used, then AI will not take over everything. And some of the things that I think are extremely important to make sure that algorithms work for different populations are around responsibility and impact. So usually when algorithms don't work the way they're supposed to work, or if they have significant biases on specific populations, we don't always know who is to blame. People just say, well, the algorithm is X, but someone created an algorithm and someone benefits from that algorithm, so shouldn't they be held responsible? And then there are questions around transparency in data and algorithmic decisions. So how do these algorithms, ChatGPT, for example, what data does it use? What does the data look like? What are the biases present in that data? Who gets to clean that data? People in Kenya and India and a lot of countries in what is considered the global South that get to clean that data. And there are a lot of issues that they've talked about in terms of like mental health, but also not really being paid well. But there's a lot around AI data itself that is very troubling. And data should be studied through a historical lens. And this is extremely important. So we can't just assume that data that's collected now only represents this present moment, because there's a lot of different factors that have shaped how that data set gets to be produced. And I think those impacted most negatively by algorithms should be involved in policy making. They shouldn't just be on the sidelines. They should be the one leading a lot of the discussion. And a lot of the advocates, a lot of the people who talk about AI bias and the issues with AI tend to be people of color. And so we want everyone to be talking about this, not just people of color. And all data sets should be robustly integrated. And what this means is when you get your data, even if you're not working in AI, just working in a clinical setting and you have a data set, there's some questions that you can ask that can help you identify bias in your data. And these questions that I have on the screen specifically were inspired by a paper called Data Sheets for Data Sets for anyone who's interested. And they basically have a list of questions that help you think about your data very carefully and think about what are some of the issues that can exist in your data. While your data might not be 100% unbiased, it's still important for you to know the biases in the data. So when you do train an algorithm or you do use the data for a specific purpose, you know what the limitations are and you can state what those limitations are. Representation and power, I think, is extremely important. So it's not just about having people at the table, it's actually making sure that they have the power to make decisions when they're at the table. So having more diversity in who gets to make AI models, having more diversity in the data sets that are being used, so not just who is represented in their data, but make sure that they're represented well in that data sets, and having communities, I already mentioned this, but having those communities that are impacted by AI have a major say in the decisions that are being made. And this will reduce the risk of models that perpetuate harmful biases. It would also help to make sure that algorithms do not only benefit some populations, but benefit all populations where possible, and when they cannot, to be able to say that they cannot benefit these populations for the following reasons and can only be applied to very specific populations. It can also increase understanding of health disparities and inequities. So by bringing different people into the room to have that conversation, people can highlight things that maybe I don't see or a computer scientist doesn't see. And we need people from different backgrounds. We need historians, we need social scientists in the room because they bring very unique insights into how data should be treated, how data should be collected. So I'm gonna end by just giving a couple of examples from my work. So going back to what is health equity. And some of the work we've been doing recently has focused specifically around historical policies and resources. So how can we use AI to study the impact of historical policies and present-day policies? And how can we use AI to better measure resources in different neighborhoods in the US? So this is a data set, this is a different data sets that I tend to use. I'm going to talk specifically about remote sensing data and mobile phone data. So earlier this year, we published this paper that looked at the association of neighborhood, racial, and ethnic composition and historical redlining with built environment indicators derived from street view images in the US. And so we have a colleague who has been working on collecting data on neighborhoods in the US, and they had millions of street view images that they had collected. So these are images that capture houses, capture streets, capture trees, and the data was processed to basically create indicators of how there's different things, how often there's different things happening in different neighborhoods. So looking at the presence of green spaces, looking at the presence of dilapidated houses, looking at different housing types, whether it's single family home or apartment buildings, and several other indicators, so things like crosswalks. And so we wanted to look at how this differed for different neighborhoods based on racial and ethnic composition, but also go back and look at the 1930s, how different neighborhoods were assigned different grades by the Homeowners Association in the 1930s, and whether we could see the same disparities in access to resources today. So just to go through a little bit of history. So during the 1930s, the Homeowners Association created color-coded maps to delineate areas that they deemed risky for investment. And they used very overtly racist criteria. So A represented predominantly white neighborhoods, and C and D tended to represent predominantly Black or minority neighborhoods or racial and ethnic minority neighborhoods. And there's been quite a few studies that have looked at how different neighborhoods were graded back in the 1930s and the association with present-day health disparities, including things like preterm births, asthma, and mortality. And so what we found was, by looking at 59,000 urban census tracts, when we compared neighborhoods based on racial and ethnic compositions, predominantly white neighborhoods tended to have access to resources that were good for health and resources that have been shown to encourage health, compared to minoritized racial ethnic groups or neighborhoods that had predominantly minoritized racial ethnic groups. And then when you moved from the redlining grading from A to D, access to resources got really worse. So if you compared D tracks to A tracks, there was significant disparities in access to resources that promote health. Another study that we did during the pandemic was there was a lot of discussion around how different groups were responding to social distancing at the beginning of the pandemic. So some people were claiming that there were individuals who they were seen around who were not social distancing. And so we wanted to look at how income was associated with whether someone actually responded to social distancing or not. So we looked at millions of mobile phone data where we could tell where where your home location was and where you went to work and where other places that you went to. And what we saw was that before the pandemic, the lowest income groups of people that resided in neighborhoods with the lowest income spent the most time at home. But right at the start, after the pandemic started, there was a significant switch. So higher income groups, the popular ones, started spending a lot more time at home because they could work from home. Lower income groups were the ones that were spending the most time outside of the home because they were doing what were considered essential jobs. So they were the ones that were being most likely to be exposed to COVID, most likely to get infected. And what we also saw was that even before the social distancing others went into place, higher income individuals were already spending time at home. So as soon as the pandemic started and people knew that something was coming, they started working from home. So if you just look at this relationship and how that correlates with whether time spent outside of home is the inverse relationship. So the people from lower income neighborhoods were spending more time outside of home because they had to go to work. We also looked at how much time was spent in different places, and there wasn't a lot of significant difference across the different income groups. And basically what we were arguing in this paper is that social distancing was important, but you could only social distance if you had the luxury to social distance. So if you could actually work from home, if you didn't have to see people and be around people, if you didn't have to go to work, then you would social distance. So there had to be a lot more policy in place to make sure that those people who were doing essential jobs were protected and not constantly being exposed to COVID. So I'm going to end by just saying data and algorithms can be used to create a more equitable and inequitable world. And I think we all have a place. We're all able to contribute to that. So thank you so much. And I'll take questions.
So here's one from Robert. It says, in case you, aside from your important work to change the AI paradigm, is there a sweeping movement to correct the existing inaccuracies in AI tools when it comes to race? If so, who is part of the movement?
Thank you. There are many individuals who have been working on AI bias for a very long time. And as I said, a lot of those people are people of color. And a lot of times, most of the leading voices are women of color. They're the ones that have been calling these issues for a long time. So they have proposed solutions. There are ways in which we can do this better. There are ways in which we can make AI better and make sure it benefits different racial groups. But the people that need to take that and actually implementing it are not always doing that.
So you mentioned earlier about different methods of doing research. Is there one method that you think is better than another method? Now, I'm not a researcher, so I'm not sure with all of the methods, but do you think one is better than another?
I think it depends on the goal of the research. I think if the goal of the research is to serve specific communities, then those communities should be involved in that conversation and should have input into how that research is done, and how that research is then used to create policy. But I don't think there are definitely methods that are bad, but I don't have a ranking of this is, you know, the only way to do this or the one way that we must do things. Was that the question?
So in general, I know clinicians are very focused on trying to use evidence-based care, to give evidence-based care. But when we reflect on what you're talking about, a lot of the evidence isn't accurate for specifically for some populations. And how can a clinician really think about that? Because we know that there are lots of issues related to race in medicine, and yet this kind of comfort that, well, I'm using evidence-based care makes clinicians feel better about what they're doing, but it may not be helping. And I don't know what advice you would have to clinicians.
I can think of one example that I really liked. It was an example around using algorithms to look at no-shows in hospitals. And in this particular case, they had patients who were not coming to the appointments, and so they would schedule over them or make decisions over them. But for this particular hospital, instead of just saying, oh, this patient didn't come to the hospital, they actually reached out to the patient and had a conversation with them to understand why they didn't come to the hospital, and found that some of these patients didn't have access to health, childcare, some of them didn't have transportation. So instead of just making a decision, they thought about how do we provide those resources to the patient so next time they can actually come to the hospital. So maybe that's one way of creating solutions. Like instead of assuming that we have all the evidence and the data that we're using, actually talking to the people that we're trying to serve to understand what are they experiencing and how can we address some of those barriers to care.
Hi, thank you so much for a wonderful presentation. My name is Jen Carroll, and I'm a family physician in the Department of Family Medicine. My question for you is you kind of sort of answered a question that was bubbling up for me as your presentation went on around tools or theoretical frameworks or models to kind of help us close the gap on some of our biases or thinking blind spots around how we think about issues of data equity. And one example that I recently learned about was in a course that I took called We All Count Foundations of Data Equity, based out of Toronto. And they, in that course, presented some really amazing tools to help you kind of as you're conceptualizing a study concept or thinking about your data early on, you know, right, really, really early on. And so, and you mentioned in one of your slides, you had a great set of kind of conceptual questions to think about this also in that paper that you referenced. And I know there's also a recent, maybe not recent, but a NASM report on AI and machine learning and kind of infusing principles of equity into that kind of thinking. I'm just wondering if you have any tips or other kind of go-to tools or resources that you'd recommend for us to kind of continue to learn about this.
That's a great question. I'm trying to think. Nothing comes immediately to mind, but I think it depends on like what you're looking for and what might be most useful to you. There are definitely papers like the one I mentioned that have been developed, and then people have taken the paper and actually developed a tool out of it so that it's more implementable and actually show examples where you can use it in different scenarios. Yeah. We can definitely talk after this and I can try to find some and share with you.
And then I think we have some questions in the chat. So let me get those and then I'll come back to you. Okay.
This is actually perfect for the referencing of the tool. Do you mind just sharing the name of that again, please? data sheets for data sets, the paper? Great, thank you very much. In that case, we also have a question from June Yang. Is there any post hoc method to account for equity among those existing AI algorithms?
There are algorithm auditing tools that have been developed. Some of them are available online. And so one of the authors that I mentioned, let me go back to that paper. So the first author on this paper actually has some tools that are available online that people can take a look at and use. But I think a lot of the conversation today is trying to push for a lot more testing before we even deploy algorithms. Because once we deploy them, they're going to have impact. And if they're going to have negative impact, it's going to be wide scale. So how can we prevent that from happening in the first place instead of thinking about after the fact?
Gentlemen.
Can you go one more slide ahead? Or maybe two. The one with pulse oximetry in it, the headline about that. Okay. Like in your first example, you were talking about like a patient meeting with their doctor and how like depending on the race of the patient, it basically gave like different outcomes. And I'm thinking through that modeling structure and thinking maybe that model, maybe that algorithm would be better without race. If you just have like a intercept where everyone gets at like the maximum amount of questions, right? But then this headline here, looking at pulse oximetry, if like the pulse oximetry metrics are not accurately capturing like oxygen status dependent upon skin color, that's like an example where it's really important to include like skin tone in that. And so the first example, we have like better not to include skin tone. The second example, we have like better to include. Is one of those like a better default? I'm sure there's like a case by case basis, which makes it difficult. But yeah, is there like a default? Yeah.
Yeah, there isn't. Yeah, I think it has to be done case by case. And I think that I would also argue that that's the case for equity, because if we try to apply one thing to everyone, then we will not have equity. So for us to advance equity, we have to think case by case.
We have a couple of other questions online.
Can you give an example or two of beneficial race corrections?
Like where it's been done before? I mean, this is one example. This paper actually has, within the paper, they talk about how they corrected the algorithm to fix the problem. So that's one good example. I think that there's been at least a couple of other papers that have talked about similar things and how to make sure that algorithms are working well. I don't know if that was the question that was being asked, or maybe it was something else.
So I can just move across. That's probably better. I'm sorry. Sorry, friends. How can we use this knowledge of bias to do post-data evaluation with a human in the loop? What factors should we focus on for evaluation of likely bias?
I think it depends on whether we want to evaluate the data or the algorithm, if we're talking about algorithms in this case. So if it's data, then we go back to the same questions that we had on the previous slides. And there are a lot more questions that you can ask, like what are the issues? What are the potential biases in the data? Because they haven't changed just because you've already done analysis. The same issues will be there. Similarly for algorithms, there are also algorithm auditing tools, like I mentioned, that you can use to check your algorithms to see if there's bias present in them.
Great talk. I actually had two questions, and full disclosure, I'm a statistician and we have statisticians in the audience. So my questions were, so first one was, you mentioned the data sources and you mentioned wanting to do data for social good, but I noticed that one of your data providers is Amazon, which may, some people would not say their company necessarily designed for social good, they're designed for capitalism. So I guess one question is sort of when you sort of have those engagements with data providers whose purpose might not be the same as yours and don't align, like it feels like it's a very political negotiation. My second question was, I think you alluded to one of the points making that like we need better data and we need to empower sort of underrepresented communities sort of with that. Now, having said that, right, we also know that there's just been, especially in medicine and healthcare, there's been a long history of distrust. So I guess my question is, how would you build trust from these communities to be able to get better data? Thank you.
I feel like the questions are getting harder. Um, I do agree with, I think there are quite a few of the companies that are listed that are questionable. And the argument that I've been trying to make, and it's something that like, it's still difficult sometimes ethically to justify using some of this data. These companies do collect this data, whether we use it for public health good or not, they collect that data and they are going to use it for their own purposes. And so what we're basically trying to do is saying the data is already there. Can we repurpose it for good? But I do agree, like, yeah. Your second question was, remind me. Building trust, yes, that's always an important one. And I think during the pandemic, there was a lot more conversation around this, and there were a lot more papers and commentaries that were written about our responsibility to build trust instead of expecting to be trusted. I can reference like some of those ones. There's some really good ones, but that basically describe how we would go about building trust, and it can take years. It's not something that's going to happen overnight.
We have one more online, if that's okay, and then I see your hand back there. Are you aware of any efforts to standardize demographic data reporting? And separately, how do you recommend assessing whether a study result is applicable to the target population you are trying to apply the findings to?
The first question, OMB is working on creating new racial and ethnic categories, and they had conversation this year. That's the Office of Management and Budget. They're responsible for creating those categories. And earlier this year, they did have like open, what is it called? They had a meeting where it was open forum for the public to come in and give an input about what racial categories they want to see and whether what they were thinking about even made sense. And so there was a lot of input, different organizations provided input in that. How do you evaluate whether your model is impacting the groups that you want to?
How do you recommend assessing whether a study result is applicable to the target population you're trying to apply the findings to?
I think it's possible to see that in the results itself. Like when you do analysis, what exactly are you finding, and does it make sense? Whether you're thinking, because there are frameworks, equity frameworks that allow you to ask certain questions when you're working with data or you've done analysis to see if it's actually, whether you're thinking about racial equity or other types of equity, whether that is actually applicable. So that there are those resources. Yeah. That's all I can think of right now.
So I think this is just a slight rewording of the question that was just asked online, but I think I'm coming more from an advocacy perspective rather than a research perspective. Do you have any thoughts, or do you know of any resources to help advocate for better standardized demographic data? I know a lot of times we deal with like, these are the categories that the NIH, wants you to report. And you're like, actually, I can get better categories. And how can we go to our administrators and grant reviewers and things like that and advocate for kind of evidence-based what we know is a better way to collect the data?
That's a hard question. I haven't had to do that, so I don't know what would be the best way to do that, apart from saying if we look at these different racial categories, it would help us see disparities or inequities better, or can help us create better policies. I don't know if there's another way to do that beyond that. And I'm really hoping for the OMB categories, because some of the input that was provided was for creating a lot more options beyond just grouping different ethnicity, but also recognizing that we have a lot more ethnicities than what is usually provided, and allowing people to even input what they want to input into those, basically have an open box option if possible, but also have the option of allowing people not to opt in into any of those categories as well.
Thank you for the very nice talk over here, Michael David. I do some AI work myself, and a lot of the times you get is how many samples do you need? So in this context, is there a threshold to find some of these things that we're talking about, or is there a sense of how much data you need, even if it's good quality, not good quality, but yeah, what's the sample size?
Are you a statistician? I actually don't have an answer to that. For some of the work we've done, we've always had this challenge of deciding when is it good to exclude a data point, when does it make sense to exclude a data point, and when do we need to keep a data point even if we don't have. So let's say we're looking at neighborhoods and we have neighborhoods where we don't have good data. Should we still keep that and use that as a point for advocacy for better data, or do we exclude it from analysis? Those are questions that we always grapple with. And I don't have like one answer. I think it depends on the situation and what you're trying to accomplish.
Thank you. Having been involved in community organizing for 55 years, and I'm always reminded of my grandfather who said something to me when I was 23 years old. And that was, in order to have friends, you have to be a friend. And in terms of going out into communities of color, white, Asian, whatever, if you don't continually do that and only go when you have a project you want to use them as guinea pigs as such, they're always suspicious. And you always have that lingering feeling of the Tuskegee experiment over anything you do in terms of racial kinds of investigations.
Then we have one more question online.
First of all, thanks for the superb talk. Could you comment on what steps banks should take or have taken to adjust their algorithms for loans to account for their historic biases? Do any of these lessons apply to medicine and public health?
I don't know what banks have done. Yeah, I don't have any specific example from banks.
A specific example of that is there are 24 certifying boards for physicians who bring you all the medical specialties in the United States. There's 126 different certificates. Those are given based on examinations with items. I believe all 24 of those boards have already completed reviewing every there are literally tens of thousands of items in these question banks. And I believe they have all been reviewed by diverse groups of people for bias related to race. And someone early, maybe it was you, Janet, when you said they're very interested in evidence-based medicine. There are decisions to be made in the diagnosis and management of patients that change because of the racial information, like pulse oximetry. And then there are others that there's no reason for them to be there. I don't know the exact numbers, but when they did that process, there were tens, not thousands of questions that were tossed out because they were racially biased.
Full disclosure, I'm a statistician, so figured I'd preface that. So my question, it seems like when you use race in these algorithms, it either propagates or attenuates the bias induced by racism. So it's acting almost like the surrogate, but it's unpredictable about which way the bias will go. So a trick we use in statistics is to create a validation set where we know that bias doesn't exist and use that to remove that bias from our observational data. Is there anything that exists like that in your work with regard to race as a surrogate?
I don't have a specific one in mind. There is quite a very active field focused on AI biased and trying to create fair algorithms, but they don't always work. Like using quantitative approaches or computational approaches don't always address the issues that people are trying to address. And yeah, to answer your question, no, I don't have a very specific example.
Well, thank you everyone for joining us today for this really rich conversation.